Good morning. When Phil sidled up to me in the coffee break yesterday and said, "Psst, want to chair a session," I leapt at the chance. My life has been sort of devoted to spinal biomechanics, and Saeed, our first lecturer, is sort of hero of mine. When I first started in the late 80s, he was already well established doing finite element modeling of the spine at a time when finite element modeling was a really difficult thing to do. He even wrote all his sort of own solver code to do it, which put him right at the front. So it's a pleasure to welcome Saeed Shirazi-Adl to give our first keynote talk.
Right. Thank you very much. Good morning, ladies and gentlemen. Thank you, Mr. Chairman. I feel a bit old by the comments. And Philip, thanks. It's a great pleasure to be here to present my talk. Despite considerable progress in the area, back pain remains still as a problem to patients, to healthcare professionals, and to the society as a whole. Now, a few issues in this area which prevent proper management of treatments and prevention of low back injuries remain the fact that we don't have a good way to measure, to determine muscle forces and spinal loads and trunk stability, and from there to identify tissue-level stresses and strains, and then compare it to the tolerance levels. Actually, this third area here is the one in need of much more work for those who want to contribute to this, to the low back pain. What I'm going to present mainly works around the first item. Now, the loads on the spine are primarily generated by muscle forces, and that's due to the lever arm disadvantage. The pioneering works of late Alf Nachemson from 1960s on measurements of intradiscal pressure have contributed a lot to our knowledge of the loads on the spine during common activities. Then it followed by some other researchers, and on the right you see the Wilkes lab, the tests they did on one subject during various activities. Then you can add to that, for as far as the direct measurements are concerned, the instrumented vertebral cage by a group at Charité, Anthony Roelman, and so on in Berlin. They've done a considerable amount of work to evaluate the loads transferred through the cage. Now, in order to have a better knowledge of the loads and muscle forces, we need to go to model studies, and we're facing with the redundancy. There are a number of methods available. For a long time, people have used reduction method, which naturally very simplified and is still using in some applications. Then optimization, which needs a number of criteria in it. Then it's prone to the limitation of inter and intra-individual variabilities. Then at the same time, there's been a lot of application of EMG-driven, which is naturally biologic-based, but there are concerns on force EMG relationship, limited EMG measurements, crosstalk effects, and equilibrium. And later on, it came about 15 years or so, the works to assist the EMG-driven model by optimization in order to satisfy equilibrium, then by introduction of gain factors, which there it comes a large range of variation in gain factors in various models. We've used for the last 2 decades on the kinematics-driven FE trunk, nonlinear FE trunk model, which is biologic because we apply the measured kinematics directly along with external loads. And here is, for example, this is the model. This region is deformable, the rest rigid. The Gravity is distributed at different levels. Musculature is there. Nonlinear properties are taken based on years of my own work, plus many experimental studies. Now, as far as the model is concerned, the musculoskeletal model of the trunk, we need in vivo study, and we need the nonlinear transient FE model that we have. The in vivo study would provide trunk kinematics, maybe with surface EMG or not. We prescribe or drive the finite element model with the trunk kinematics. We evaluate muscle forces and internal loads. Then if we have EMG, we qualitatively compare our muscle forces with the normalized EMG. Then the question is, how do we get from the left side to calculate muscle forces? I give a bit more information here. So we have the finite element model. We prescribe kinematics. We input gravity, inertia, external loads. All together, for each degree of freedom which is prescribed, we get a load. That load would generate a constraint equation in our optimization, which along with inequality, constraint equality equation, which along with inequality equations would allow us to solve for the unknown muscle forces. These muscle forces are then input into the model alongside the trunk kinematics and gravity again. And this iteration is repeated till we reach convergence. When convergence is reached, muscle forces are calculated. We do a stability analysis. I'll talk about it a bit later on. As far as the passive component muscle forces are concerned, we can either introduce them before optimization or as a post-processing after optimization. What I'm going to talk today is on two subjects due to the naturally time limitations. Two important points is the single joint or single level free body diagram versus multi-joint equilibrium in a system such as trunk, which is multi-joint. I'm going to compare a number of methods I describe later on. Then, on the second part, I'll discuss the trunk stability, and I refer also to the wrapping compression load applications. Now, the first part, as far as the trunk is concerned, is multi-joint. So you have to have equilibrium in different planes and at different directions. However, many models consider only one single level free body diagram and then satisfy these equations at that level alone. Now, in order to see the error involved with this, we've done here, gotta get close. We have here the two different loading conditions. The upper one is the 180 Newton in hands at 65-degree flexion rotation of the trunk, and then the second set of loading here is upright with no load in hands. If you apply the single level free body at one level only, either this level, or here, you will see that loads you're going to calculate in muscle forces vary considerably. On the left side is the KD model, which is multi-level equilibrium, and compared here with EMG mean and standard deviation. So you see the large differences depending on where you cut for the single level free body diagram. Now, if you calculate muscle forces at the L5S1, which is usually done, and then apply these muscle forces to upper levels, you will violate the equilibrium at the other levels. And here it gives about 40% index of violation of equilibrium under this heavier load, and a smaller amount of about 10% under upright standing. Now I go further here to compare what Denis Gagnon at Sherbrooke University did is compared the multi-joint EMG-assisted optimization with single-joint EMG-assisted optimization. So these two are both EMG-assisted optimization, one multi-joint single. And I'm going just to show that for the task of 5.2 kilogram asymmetric held at 90 centimeters, the total global forces of this magnitude for multi-level equilibrium is nearly twice the single level when it is done at L5S1. This generates such a huge differences in compression and shear forces. Here again, the work of Denis Gagnon. On this axis, you see the differences between compression forces by multi-level equilibrium and single-level equilibrium EMG-assisted optimization when performed at different levels. For the subject flexing from upright standing to the full flexion. You see the huge differences reaching 544 Newton, which is quite substantial between these two models. The same when you carry asymmetrically 5.2 kilogram load. Again, the same differences when done at different levels, reaching 671 Newton between these two models. Here again, I compare now the RKD model with single-level EMG-assisted optimization for a subject carrying 20 kilo nearly held at 55 centimeter away from the L5S1. I'm just concentrating on the total muscle forces. You see KD gives one single, while the single-level models give two, depending where you cut and develop the equations. There is a huge differences between these two and the KD model, and compressions are much larger than KD model. Now we compare this with the measurements of Wilke for the same tasks performed on the third column here. The first column is the KD intradiscal pressure. Second, the single-level EMG-assisted optimization. For lighter tasks, there are not much differences between them. Nevertheless, for heavier tasks, there is a huge difference between when you use single-level EMG-assisted optimization. So, in conclusion, in a multi-joint system, single-joint models yield erroneous estimations, with errors increasing in heavier tasks. Now I go to the second part of the talk on the stability. Our model studies plus experiments of Lucas in 1960s show that the total ligamental thoracolumbar spine T1 to S1 can carry only up to 2 kilogram conservative load before reaching instability. And by instability, you can consider hypermobility, which is also well comprehended by the clinical colleagues. Then, if you consider only the lumbar spine, you have about 80 Newton to 100 Newton maximum load you can apply before instability. Then the question is, how could the spine carry 3, 4, 5, 6,000 Newton under various tasks? Some of them are daily activities. Before continuing on that, I get right away to the very important issue that have hindered the development of experimental model studies. How could we apply physiological loads in model and experimental studies? If you apply conservative loads, you will have instability, you have artifacts. So this has been a major issue. In 2000, using a contact algorithm, I developed a wrapping element which wraps around some predefined edges. When you define the edges, you can wrap them around entire T1S1, going all the way, following the curvature during the formation. Then with that type of loading, you can go as much as you want as far as the strengths of the tissues are concerned. Here, 1,000 Newton is applied with zero shear force artifacts and moments, no instability. There is a bit of deformation, which is natural due to the axial compression of the joint. The joints are purely under compression. Then when you apply the same wrapping load, as you see here, the black line, you can see the effect of large compression of 2,700 and the stiffening effect of it in flexion rotation and axial rotation. These are not only in the spine, it's clearly the case in other joints such as knee joint too. Compression increases the stiffness of the passive tissues. The pioneering work was experimentally done by Pat Warden in Chicago, in which the cables on both sides are guided by hooks during experimental studies and then followed by many rollmen. Now this type of loading is used in model studies and experimental studies by various groups. Now I go back to my stability case. What we do is first we evaluate muscle forces. Then we come to this equation of Berg-Mark. I understand it's a linear equation between the stiffness of muscle force, length of muscle, and the Q is a stiffness coefficient which is unitless. Then we use nonlinear analysis as gold standard, and then a set of other methods which we can use in either a static criteria of instability or dynamic in order to identify the force reserve or margin of stability of the system at deformed configuration. So this is the equation I use, and I'll refer to Q, which is based on the work of the Berg-Mark. So if you look at this equation, we initially give Q, let's say 100 or 200, then keep decreasing it up to the point where the system becomes unstable. We call that Q critical Q. So we can't go below that Q. And the Qs you hear here are the critical Q or muscle stiffness coefficient for these types of tasks you see. Do not forget, as the Q goes lower, drops, stability margin increases. So the lower Q indicates higher stability for that position. Upright standing, load close in kyphotic posture, close in lordotic, and so on, load held lower or upper. You will see different Qs showing different indications of stability. Lower is more stable, so it's better. You will see the subject when they bend forward, especially with load, you don't need any muscle contribution for the stiffness. So Q can be even 0 and system still be stable. This is the work of late Granata, in which loads were held in hand at different heights, but with the same lever arms. As the load elevation increased, so did the recorded EMG in antagonistic abdominal muscles and agonist extensor muscles. And naturally, then the spinal loads that they didn't calculate it. This is our model studies in which we want to keep Q critical at 10. You can choose any number, we chose 10. So for that one, you see as the elevation of load increases for the same test, you need more antagonistic abdominal activity. Along with it, you will have larger agonist activities, which overall, I don't want to get to details of this figure, it's very crowded. You would get larger forces as you keep Q constant. You go from one curve to another as the height increases, then compression and anterior shear force increase naturally. Now I go to some dynamic tasks. This is forward flexion either as fast as possible by subjects or intermediate speed or quasi-static slow, it comes to the same thing. So the subjects start from upright, they flex to the maximum, which is normalized to 1, and then go back to 0, which is upright standing. You notice here the faster is more stable. This is Q value against the normalized trunk rotation. As the subject goes to flexion, after a few degrees, you see system stabilizes. You don't need any muscle really, and more so in the faster movements. And then as it goes back at one time, then you need muscle effect to stabilize the system. By the way, these were 2 different subjects, left and right, among 12 subjects. This is an interesting case, a study done by Cholevicki in a sudden release where the load of 300 or 172 applied, suddenly released. So initially you had abdominal activities as agonists to counterbalance the moment of the load. Then when you release it, they should switch off, and then since you go forward, then you would have back muscles. These are the model studies for 2 different loads. You will see how the model, this is the power of kinematics application, that how the model can go to predict the latency. This is the beauty of application of velocity and acceleration recorded in experiments. You see the abdominals are active at these two levels of load, then they remain active up to some level, then the agonist, in order to break the forward movement, they come into the play. With that, the Q initially, because of abdominals, the system is relatively stable. Then it would be less stable because the abdominals are no more active. This is for sudden perturbation forward, sudden application of the load, not release. So we have a preload of 5 Newton and the perturbation of 50. The load here is in green. After the sudden release of this 50 Newton, you would see the load recorded and displacement recorded. We apply this with external loads into the model. So the model predicts this extensor muscle activities. You see some latency here, then rising here in order to prevent further forward flexion. And with that, you have very large compression forces exceeding 3,000 Newton. As you look at the stability of the system for one subject, system was less stable before application of the perturbation, and then became more stable as the reflection involved. If you see the statistics of the 12 subjects, this is with 3 different conditions of 5 Newton post-perturbation, 50 Newton post-perturbation, And this is when initially subject was flexed, before perturbation. The most stable system is the green, which subject was initially flexed in all three conditions of before perturbation, during latency, during reflex, and voluntary actions. And this is my final, at least graph of results here showing some more recent results. If a subject carries 120 Newton pull force, when you carry, the load is pulling away from you at this height in your hands, then you change the orientation of load. As you go from 90 degrees, look at the mannequin here, the load is in gravity. As goes to 0, load become horizontal. As goes to minus 90, load pull become upward. Then we see a stability as a function of orientation of the load. We did it for 3 different Q values. We don't know what muscles would provide. So at the Q of 5, the system up to minus 50 upward is unstable, then becomes slowly stable. This is the stability margin. What it means is that how much more load you can apply in that orientation, in addition to the external load already applied. So it gives a measure of stability of the system. When it's 0, that means system is unstable already. So when you go to Q higher or highest Q 25, system is stable from the beginning, although the reserve is much lower. This is much higher reserve. Now it's interesting to see how this stability is provided by 3 groups of muscles. This is external global muscles. This is extensor global muscles. This is extensor lumbar muscles. And in brown, you see is the abdominal muscles. So initially, when the load is downward, this is the way these muscles work, and stability increases. As they drop extensor muscles, the stability decreases. But then suddenly, as the load turns upward, abdominals become, moment changes direction, and abdominals become agonists, in which case they suddenly increase the stability considerably. Now, what are the conclusions of this part is that if you change the passive stiffness due to any reasons indicated here, if the passive stiffness decreases of the ligamentous spine, you need more muscle forces, spinal loads, and stability decreases with it. Then, in contrast, as the passive spine stiffness increases, muscle forces, spine loads decrease while stability increases. If you activate antagonistic muscles, generate coactivity, then muscle forces, spinal loads overall increase, so does the stability. If you carry loads higher, at higher elevation, stability decreases, and with that, we need more muscle forces and spinal loads. If the load orientation is more pull is upward, stability is higher, but the muscle forces, spinal loads are lower. But if you apply it at the extreme in gravity, apply the pull downward, the stability decreases, but the forces, spinal loads and muscle forces increase. So here are some of the past major contributions of biomechanics community to this area. In prevention to reduce risks involved, in treatment to improve outcome, in sports medicine to enhance performance, and in education for better care of one's spine. And we have more to do in these areas. And with that, I end my talk. Thank you very much.
Thank you, Said, for a whirlwind tour of how spinal mechanics has come on. I was going to say that I grew up with Judith Meakin, but she's much younger than me and also much shorter. But I think an ideal person to take us forward and give us an indication of where spinal mechanics and biomechanics is going.
Hello. So there's been a general trend since ISB began for models of the spine to move away from fairly simple generic models to much more sophisticated models, as we've just heard about. and to incorporate more and more subject specificity. And it's a very attractive idea that as we move forward in the next 25 years or so, that these models can be developed further so that they can provide us with an even better understanding of the spine, and by incorporating more subject specificity could be used to perhaps predict spinal loading within individuals, and to predict risk in manual handling, and to predict the outcomes of surgery. So I'm going to think in this talk about what kind of tools we have or are developing to help us do this, and what other things we need to understand and know about. But first I want to think a little bit about all the things that affect the biomechanics of the spine and how variable they are within the normal population before we start adding on some of the complexities of pathology and degeneration. So if you were to look at the person sitting next to you or near to you, you'd see that you're kind of similar, but you're not exactly the same. And if I was able to take the audience and if we were able to have a look at your spine, we would probably find from data that we already know that you would probably have quite a variation in the strategies that you use to balance the spine and the upper body on the pelvis and the hips. And these differences are associated with difference in spinal curvature. And data that we've taken in the last few years, looking at the curvature of the lumbar spine, would suggest that we would probably find in healthy people, such as yourselves, that the total curvature of the lumbar spine varies quite considerably from about 20 to 70 degrees, and that this curvature also varies in the way it's distributed along the lumbar spine. Now, we'd also probably find that you had quite big differences in the capability of your muscles, with differences with both strength and endurance. Obviously, muscle capability is dictated by a number of factors, but if we were to look at the cross-sectional area of the muscles, for example, the muscles that control flexion and extension and the stability of the spine, such as the multifidus and erectus spinae, then again we'd probably expect to see quite significant variation in this cross-sectional area, such as shown in this data from 21 healthy, fairly young adults. Now, you might be thinking, well, posture and muscles, I can change that by standing up straighter and going to the gym. But what about anatomy? Well, again, if we were to look at the vertebra, then looking at this data from Punjabi in 1992, we can see again that there's quite substantial differences in the shape of the vertebral bodies. If we look at the length of the transverse and spinous processes, which of course are important as lever arms for applying muscle forces, then we can see that the variation, and this was just from 12 healthy normal subjects, is considerable, with standard deviations between about 10 and 20% of the mean value. Again, if we were to look at the tissues, and if the unlikely event that you were to give me a sample of your disc tissue, then we might expect that, yes, again, we're finding substantial variation, and even in normal healthy disc tissue, we might expect to find a standard deviation in the modulus of that tissue, which is about 50% of the mean value. So it's quite clear that, as I said, even before we start thinking about pathologies, degeneration and so on, that we are extremely variable in many aspects of the spine that affect its biomechanics. And if we're moving forward to models that want to incorporate this variation or have subject-specific parameters, then of course we need to have the right tools to measure this. Now, we've heard about some of the tools in the Keynotes talk yesterday. And of course, imaging, as you might imagine, is probably going to play quite a big role in allowing us to assess this kind of variation in vivo and relatively non-invasively. So imaging has been used to understand the biomechanics of the spine right from the beginning of ISB, as shown in this example of radiographs taken in 1972 to try and understand the way the spine behaves in flexion and extension. And since that time, imaging technology, as many of you probably know, has developed quite considerably. We now have systems such as the EOS system, which allows us to take radiographs simultaneously in the frontal and lateral planes, giving us a really good idea not only of the shape of the spine, but also how that interacts with the pelvis and hips and knees and so on. And from what I understand, this technology is also being developed currently so that we should be able to get an estimate of the bone mineral density at the same time. In addition to the EOS, we also have upright MRI now, which has some advantages that in not using ionizing radiation, it means that we can take repeated measurements of subjects in a whole variety of procedures, pretty much anything you can persuade them to do in an MRI machine. And if we're quite happy to use ionizing radiation, then as we saw yesterday with some nice videos of the knee, we can use fluoroscopy to get an idea of how the spine is moving in real time. Now, often in a model, such as a finer element model, we want to know something about the vertebral anatomy. And one of the ways, of course, we can do that is that we can image the spine using CT. And from these CT images, we can segment out the anatomy of the vertebral bodies. And there's many talks that have been presented that ISB are using this kind of technique to create finer element models at the moment. Now, if we want to produce a subject-specific model, then often one of the bottlenecks that makes it practically difficult to implement on a wide scale is the time it takes to segment something as complicated as a vertebra. And if you're trying to do a whole spine, then it can take many days or hours or days' effort to produce that segmentation. So in the future, a goal might be seen to produce computer methods that can allow that segmentation to take place completely automatically without any kind of user input. Now, there's various groups that have been working on this, and in terms of CT, it's now possible to get a pretty good automatic segmentation of a vertebra, which is very comparable to a manual segmentation, giving us a relatively quick way of segmenting out the spine. Of course, CT involves a relatively high dose of radiation, and again, as we're thinking forwards into the next 25 years, we might foresee that there's a trend to move away from CT and to try to use MR a little bit more. Now, MR's developed quite a lot. The very first clinical images taken with an MR machine in 1980 in Aberdeen, just a few hundred miles away from here, were spectacular in terms of being able to see pathology such as tumours in the liver and the spine, but weren't particularly useful for spinal biomechanics. But of course, over the last 35 years, this technology has developed quite a lot and now produces the kind of images that we're more used to seeing, where we can get a fairly good image to show us not just the anatomy of the spine in terms of the vertebra, but also the discs as well, and the muscles and the ligaments and so on. And MR can also be extended to give us a little bit of information about muscle function and other properties of the discs as well. Now, segmenting vertebra from MRI is a little bit more of a challenge because there's much less contrast between the bone and the surrounding tissues. And however, with a little bit of patience, you can segment a vertebral body out from an MR image. And some of our work looking at automatic methods suggests that although we're not quite there yet, in that it doesn't really look quite as good as we'd expect to achieve if we were using CT, there is potential there, and it could be that in the future we could develop automatic segmentation methods to work well in using MR data as well. Now, one of the things that would improve our ability to automatically segment the spine from MR is having even higher quality images that we can get at the moment. Most of the MR images that we obtain today are achieved using scanners that have a high field strength of about 1.5 to 3 Tesla. But there's various pieces of equipment being built by various groups and companies around the world that's now starting to move to ultra-high field of 7T. Now, imaging the spine at 7T is slightly technically challenging due to not wanting to put so much energy into your participant that you cook them, and also trying to maintain field homogeneity so that you get a good quality image. But there has been work done in the past few years that's suggesting that there are methods that would make it possible to image the spine at 7T, as you can see in this example here, which suggests that over the next decade or so, it may be possible to get images of the spine that are of a really good quality with high resolution. Okay, so that's posture, and that's getting a good idea about anatomy. One of the perhaps more challenging things to measure in vivo using imaging is properties of the discs, which are of course important if we want to build those into a model. So there's various techniques that are being looked at the moment using MR imaging to try and understand, to take measurements of diffusion in the disc and relate that to disc properties, and also some other groups that are looking at elastography using magnetic resonance or ultrasound. Now, all of these are showing potential that that they could be developed into a practical method. And so it's probably unlikely that we'll ever get to the point that we can accurately predict the properties of the discs in this kind of technique, but it certainly looks that there's the potential to at least get an estimate of sort of approximate properties from an individual. Okay, so we've looked at some of the variability, and we either have or we're starting to develop some of the tools that we would need to assess this variability in vivo and to incorporate it into a subject-specific model. But what other kind of things do we need to think about over the next 25 years? Well, one of the key things that I would say we need to think about is a little bit more about the relationships between these variables. So if we go back to the data that I showed you a few minutes ago from Punjabi, as I said, this shows that there's quite large differences between the lengths of the transverse processes and the lengths of the spinous processes. But if we just look at this data in isolation without knowing anything else about it, we're not really sure from this whether these two variables are related, so that we're talking about an issue of scale, where bigger people have bigger vertebra with longer transverse processes and longer spinous processes, or whether we're actually talking about completely unrelated variables where we've got an issue of shape, so that spinous process and transverse process can vary in an individual completely independently. Now there's several reasons why this is important. One of the reasons is that if we build some kind of model, say a finite element model, and we want to use that model to explore how varying a parameter affects the biomechanics of the spine, then it's quite important to understand whether other parameters are varying at the same time. Now, this can be illustrated by some work that we did a few years ago, where we built a very simple axisymmetric model of a disc, which was based on some real measurements we'd taken of sheep discs. Now, we were using this model to see, in a Monte Carlo simulation, to see how well we could match experimental measurements, or rather, how well the model could match to some experimental measurements. And as you can see from this histogram of the results from the experiments in the model was predicting some quite ridiculously high strains in the disc, which essentially said that with the load we were applying to it, we should just squash the disc into oblivion. Now, the reason for this becomes a little bit more clear if we start to plot out how the parameters that were varied in the model vary with each other. And you can see from this plot that there's a relationship between these variables that we were using that we'd based on the measurements of the discs. Now, in the model, this relationship is not included. We're assuming that all the parameters are independent, which means that we can get some combinations in the model which were not physiological. And as was very nicely put yesterday in the keynote talk in the afternoon, if you put rubbish in, you get rubbish out. So understanding the underlying relationship to the data is very important for making sure that you've got a model that can predict reasonable results. Now, another reason that it's important to understand relationships is that if we know there's some relationships there, then we can simplify our models. And it's for this reason that Kunkel et al. Have been doing a series of work recently to try and understand how various morphological parameters in the vertebra and the discs relate to each other. Because if you've got relationships, you might only have to measure one parameter, and you can use that model. You can use that to then build up a subject-specific model. As we try and understand these relationships, particularly if we're thinking about something as complicated as vertebral anatomy and the spine, I would suggest that we probably start to need to make more use of methods that can assess and characterize this variation a little bit better, such as factor analysis or principal component analysis. We've been using this in the form of doing shape analysis, shape modeling in the last few years, and found that it's a particularly useful technique for characterizing the shape of the lumbar spine and also the vertebral bodies. So for example, with the lumbar spine, rather than having to measure a whole series of different angles and dimensions to characterize the vertebra and their orientation in the spine, you can, through shape modeling, break this down into two components that sort of neatly encompass all this variation in one go. And similarly, if we're looking at the thoracic vertebra, then just within one parameter, we can describe variation in the orientation and the length and the aspect ratio of the processes in vertebral body. Some groups are now starting to look at this kind of technique for understanding vertebral morphology in 3D and using it to understand how aging affects the vertebra, and also to look at how the shape of the disc varies. So these kind of techniques are starting to come on board, and the ability to incorporate this in 3D means that it could be used quite easily within a model. But of course, as I said, these relationships, it's not just about relationships between different aspects of vertebral anatomy. There may also be relationships on a wider scale than that. Myself and colleagues have been looking recently at the lumbar shape, the lumbar curvature, and how this changes as people adopt different postures, such as sitting and flexion and so on. And this has shown that although obviously the spine changes shape as you change posture, there does seem to be a correlation in the shape across these different postures, suggesting that there's something intrinsic to the individual that's influencing this shape. And it's also been shown to affect the biomechanics when supporting an additional load and when people are asked to lift something from the ground using the technique that they most prefer. Now, these relationships haven't really been fully explored, but you might anticipate that there's something within the spine, perhaps the anatomy or the way the muscles are being used, that is dictating this intrinsic shape, and some very preliminary results are supporting this idea. So, I've talked about the different things that affect the spine and how they're very variable, and looked at some of the tools that we have or are developing that would allow us to gain information about this variability and incorporate it into models, particularly if we're thinking about subject-specific. And I've also talked a little bit about some of the things that we need to be thinking about over the next 25 years in the hopes that by 2040 we can then have a really good understanding of how the various aspects link together in order to create spinal biomechanics. Thank you.
Thank you, Jude, for an excellent talk. So, now's your turn. There are 4 microphones. Please rush up to a microphone and take this opportunity to ask some insightful questions. Number 4.
Thank you. Jaap van Dien, Amsterdam, the Netherlands. A question for Professor Shirazi-Adl. In your comparison of multi-joint and single-joint models, I was wondering whether the single-joint model is also kinematically a single-joint model, or whether it's only the kinetic constraints.
What I refer to single-level free body diagram is usually done by cutting the disc at the mid-height by a plane and then applying equilibrium equations in different directions. So they use all those models that I compared, they use the same loads, kinematics, everything was exactly, passive properties the same. But what the single level I refer to is when they cut the disc at L4, L5, L5S1, and then apply the equilibrium equations, they apply muscle forces, and so it is in the deformed configuration of the disc at the mid-disc height, under the external loads, the forces, and forces coming from the muscles.
But if you rotate the model around one single joint, you will end up with different moment arms than when you distribute the kinematics over several joints. Am I correct?
Yes, all of them are done at the deformed shapes. So it's updated geometry has been applied when you cut the single level free body diagram at different levels. They are done at the deformed, updated shape, at the final configuration.
Okay, thank you.
Number one.
Yes, my name is Rosemary Dobberdam from the Netherlands. Thank you for a very interesting talk and insight in the future. You've been talking a lot about the modeling. Could you also give us some insight how these models could contribute to supporting the therapy of back problems?
Well, there's been quite a number of studies, and we've done some in which, particularly if you consult the publications of Dr. Navid Arjman, we've compared with different tools, lifting tools and so on, and come out with the regression equations allowing the ergonomists to apply these complex models directly through the simplified regression equations to the different cases at the workplace, at the different types of lifting, different loads, postures, and so on. And we still keep working on it in order to make it asymmetric and develop further this regression equation. So there have been a number of people, such as our group, have come up with these regression equations towards the ergonomic applications, the workplace. And they are already published, and work is ongoing for further refinement and applications.
Number four.
Yes, Wafas Kali from Arts et Métiers Paris Tech. Thank you for your nice talks. I have one comment and one question. The comment is for the vertebral modeling. I think there are already published works on automatic generation of subject-specific models, particularly from the EOS systems, so using statistical modeling and using some meshing techniques. And the comment was about the pelvis. In clinical biomechanics of the spine, we know now that the pelvis has a major influence because it makes the link between the hips and the spine, and particularly the morphology of the pelvis and the incidence will condition both the lordosis and both probably the stability of the spine. Did you, for both of you, consider the pelvis in your investigations? Because it really makes the link between the lower limbs and the spine.
If I may go before, when we apply prescribed kinematics, by that I mean linear and angular displacements, velocities, accelerations, we do it at all levels, coming from the T12, or currently we're working on T11, all the way up to the sacrum, which accounts for the pelvis. So without pelvis, we wouldn't have been able to simulate full flexion and so on, or during flexion. The results won't make sense. Not only in terms of rotation of pelvis, pelvis has linear accelerations in different places during lifting, which affects considerably the results.
Yes. Until sacrum and femoral heads, because the pelvics makes the link also with the femoral heads, and I think it could be really interesting to investigate that.
In our model, we take sacrum and pelvis the same. We consider them the same, although I'm aware of a minor there is a joint with a small relative displacement, but in the model, when we call pelvis or we call sacrum, it's basically the same.
Okay, thank you very much. May I just add my own personal thanks to the speakers. I'm going to ask Donal McNally on behalf of ISB to present our speakers with a couple of Glaswegian quakes. Whilst he's doing that, could you show your appreciation in the usual manner? Thank you.